All right, hi everyone. I'm Alex Glaser. I'm a urologist at Endeavor Health and clinical associate professor at University of Chicago. Today we'll be talking about if enucleation or aquablation should be the gold standard for non-catheter dependent BPH. Quickly to go over disclosures, I have a couple NIH grants that aren't really relevant here. I am a consultant for Procept, and I'm also an investigator in some of their prostate cancer trials, but I will not be discussing the prostate cancer work today. We'll just be focusing on BPH. So the scene of BPH has changed dramatically over the last 10 or so years, as many of you are aware. And we have minimally invasive treatments, so-called true miss off-the-shelf solutions, and the more traditional surgeries like TURP, green light laser, HoLEP, and now aquablation as well. And so the question becomes, is there a trade-off between improvement in urinary symptoms and quality of life versus sexual dysfunction, incontinence, and retreatment rates? And if you look at nationally, what's still being done, TURP and green light laser are still done quite frequently throughout the country. This is Medicare data, a couple years old now, but still remains mostly the same. And TURP forever has been the quote unquote gold standard, and many urologists very familiar with it, can do a good job with it, and are extremely comfortable with TURP. However, I really think we should be moving beyond that. HoLEP for years now has demonstrated, size-independent results and proven durability better than really any other technology other than a simple prostatectomy. In aquablation, now we have, very good 5-year and longer results with image-guided robotic ablation leading to treatments that can improve voiding function as well as preserve sexual function and continence. And so, I really think to a degree, TURP should be dead. There is data for a long time that has shown that HoLEP has superior voiding outcomes compared to TURP, whether you look at a patient-reported outcome measure like the IPSS, or if you look at things like maximum urinary flow rate. And this is systematic review, meta-analysis demonstrating that HoLEP has superior outcomes compared to TURP. Interestingly, though, quality of life was not significantly better in HoLEP versus TURP in this, and I postulate that that might be because of incontinence. Aquablation, this is combined data from the WATER 1 and WATER 2 pivotal randomized trials, showed improvements in IPSS, quality of life, Qmax, and PVR similar regardless of prostate volume. WATER 1 had a 7% retreatment rate at 5 years. They only did one pass with the AquaBeam, which is now substandard. We do 2 passes these days. In WATER 2, which was the larger prostates, it had a 3.8% retreatment rate at 5 years, and less than 5% of those men went back on BPH medications. In addition, if you look at aquablations for prostates greater than 50 grams in size, aquablation had superior voiding outcomes compared to TURP, while maintaining a lower retreatment rate and without impacting sexual function. So in a lot of ways, both aquablation and HoLEP have been proven to be superior to TURP. So in this debate, should enucleation or aquablation be the gold standard? My answer is yes, but let's have some fun with it. So I'm going to go through a couple different topics and we'll battle it out whether HoLEP or aquablation takes the crown. Learning curve. HoLEP has a notoriously challenging and long learning curve. Estimated to be 50 cases, some people will say 100 with careful case selection. And of course, during that learning curve, procedures can be associated with longer OR times, higher rates of complications like perforation, bleeding, as well as higher rates of incontinence and retreatments. Any concept of a learning curve is somewhat artificial. We're always learning from our patients and from our experiences, and learning will continue through, every case you do. But there are some papers that show that of programs that try to adopt HoLEP, about 50% of them end up abandoning the procedure, either because of difficulty or complications that they encounter while doing the procedure. And primarily, laser enucleation remains centered at academic institutions, and fellowship training is certainly encouraged. In contrast, aquablation uses the techniques that are, fundamental for every urology intern, cystoscopy and a prostate ultrasound. In WATER 1, there was an average of 0.5 cases before the study started, and despite this, they still achieved outcomes that were superior to TURP in a lot of ways. People have looked at the learning curve, and it's certainly less than a HoLEP. After 4 cases, half of the cases achieved an OR time of less than an hour, low hemoglobin drops, and no significant complications. And after 30 or 40 cases, You can get to that plus significant improvements in voiding function while preserving ejaculatory function. And so unsurprisingly, there are no multi-year fellowships dedicated to learning aquablation. Now let's move on to OR time. I'm going to talk about two different studies here. The first study is a prospective non-randomized multi-center study looking at HoLEP versus Aquablation. They looked at prostates 30 to 120 milliliters in size with standard inclusion criteria, IPSS greater than 8, Qmax less than 15. Looked at 75 HoLEPs matched with 75 Aquablations, and they found no difference in OR time. HoLEP 44 minutes, Aqua 49 minutes. The other study I'm going to discuss a lot is the Water 3 randomized controlled trial. So this was an RCT that results are still forthcoming, but we have results now at the 3-month mark, looking at 88 enucleations either through LEP or HoLEP versus 98 aquablations. And they found no difference in OR time. So 58 minutes versus 61 minutes. But importantly, the aquablation surgeons had a combined 9 case experience before the trial started versus a minimum 100 case volume experience in the HoLEP arm. Now, what about safety? HoLEP, of course, has excellent hemostasis due to the mechanism of the laser. Transfusion rates generally extremely low, especially for men not on anticoagulation. Ibrahim et al. Showed in 1,500 HoLEPs a 0.8% transfusion rate. And then a recent retrospective review of aquas versus HoLEPs found no transfusions in the aqua arm, 1 in the HoLEP arm. Relatively high rate of clot evacuations in this study, 10 versus 13%, but no significant differences. If we switch over to looking at the 2 studies I mentioned before, in the prospective non-randomized study, aquablation was associated with a larger hemoglobin drop of 2 grams versus 0.4 in the HoLEP arm, but there were no differences in transfusions or other complications. And then in the best data we have, the randomized controlled trial of aquablation versus enucleation, there were no significant differences in safety, meaning no differences in hematuria, clot evacuation, or transfusions. What about same-day discharge? Well, HoLEP same-day discharge is becoming increasingly common and is even moving to same-day trial of void and catheter removal when feasible. For example, Lauren Cooley published a paper with Amy Krambeck showing 190 HoLEPs, and 90% of them were able to have a same-day void trial. And people on anticoagulation, were more likely to fail that, which is, somewhat expected. With aquablation, though, more and more people are moving to a same-day discharge with aquablation, although not to the point that's published yet, doing a same-day void trial. Kevin Zorn published 60 aquablations at an ASC. 98% of them went home the same day. 1 patient did not. I think it was a late case, if I remember the paper correctly. Ran CB on the PACU for a few hours, clamped, and sent him home. Similarly, Sean Maramati's group showed 101 aquablations, and they were able to send home 100% of those patients same day. So certainly feasible with both technologies. What about voiding outcomes? As I showed in the initial slides, both HoLEP and Aqua have repeatedly been shown to be equivalent or superior to other modalities, including TURP, in improving voiding parameters. And this slide is showing real-world data from about 2,000 aquablation cases in what's called the Icarus database versus the randomized controlled trials, the pivotal trials of Water 1 and Water 2. And with rare exception, the real-world data essentially matches the pivotal RCT data, that in the real world, you're still having excellent voiding outcomes out to the long term with aquablation. So what did the papers show? In the prospective non-randomized study, at 6 months, there was 0 difference in IPSS, quality of life for Qmax between aquablation versus HoLEP, equivalent. And what about in the RCT, aqua versus enucleation? 0 difference in IPSS scores. So you're getting excellent improvements in IPSS regardless of technology used. The one place where HoLEP does beat aquablation is in the Qmax. So at 3 months in the RCT of Aqua versus HoLEP, Aqua achieved an average Qmax of 20, whereas HoLEP achieved an average Qmax of 28. However, if we're in a debate format, I will certainly say that men don't really care how fast they pee, if it's 20 versus 28 milliliters per second. It doesn't correlate with quality of life or any of the real patient-reported outcomes that we really care about. Now, urinary incontinence. Many of the early HoLEP or enucleation studies really didn't adequately capture incontinence, and instead only measured the IPSS, which again has no questions about incontinence, and then looked at Qmax and PVR. But most studies cite a 1 or 2% long-term permanent urinary incontinence rate. Things like older age, larger prostate volume, and pre-existing urge urinary incontinence are associated with that post-op incontinence as well. In a very large 11-year experience of over 2,000 HoLEPs, Guild et al. Quoted a 2.2% permanent urinary incontinence rate. And this is one of my soapboxes that I stand on. Any urinary incontinence is associated with worse urinary symptoms and worse quality of life, whether you measure it or not. This is looking at the IPSS versus a different questionnaire called the Learn SI10, developed from an NIH initiative, which shows that men who have incontinence, which are the colored dots in the graph, have worse symptoms at baseline. They also have worse quality of life at baseline, meaning that whether you measure it or not, the people with worse quality of life or worse bother are guys who leak. And this holds up in the post-op setting as well. Whether you measure it or not, post-op pain and urinary incontinence are associated with worse symptoms and quality of life. So you have to measure it. So what do the studies show? In the prospective non-randomized study, they didn't use a patient-reported outcome measure for urinary incontinence and instead used a PAD measure, which does add some subjectivity to it. But in the HoLEP arm, there was a 4% urinary incontinence rate at 6 months versus 0 in the Aquablation arm. Now, that wasn't statistically significant, but if you look at the RCT, which actually used a patient-reported outcome measure for incontinence, the ICIQ, the enucleation was associated with significant urinary incontinence at 3 months, stress incontinence 9% in the HoLEP arm versus 0 in the Aquablation arm. So I think we have a clear winner in this category. Now, what about ejaculatory dysfunction? I think we're going to have another clear winner. With Aquablation, there's about an 80-90% rate of ejaculatory dysfunction. For Aquablations, I quote about a 10% anejaculation rate and a 10% reduced ejaculate rate to most of my patients. In the prospective non-randomized study, they had a 90%, 89% ejaculatory dysfunction rate in the HoLEP arm versus only a 6.6% rate in the Aquablation arm. In the Water 3 RCT, we're using the MSHQ EJD to accurately measure ejaculatory function. And in the Aquablation arm, 15% rate versus 77% in the HoLEP arm. So again, clear winner here with the Aqua. What about surgical retreatment? HoLEP has been associated really with the best long-term surgical retreatment rates, other than perhaps a simple prostatectomy, which is, of course, more morbid, over a very long experience. So in a paper by Guild et al. That I quoted before, 11 years, 2% surgical retreatment rate. And then using more of a database, HoLEP found a 1.5% reoperation rate, much lower than TURP, for example, at 4.5%. In the Water 1 and Water 2 studies, again, they only did one pass in Water 1, which was probably inadequate, which led to a 4% surgical retreatment rate at 5 years in the Water 1 study. In Water 2, that rate was around 2%. In our data from Icarus, which is about a 2,000 case series, those rates are even lower than in the RCTs, meaning 1.3% for prostates less than 80, and again, 1.3% for the 80 to 150 arm. However, long-term follow-up, especially from Water 3, is really going to be critical. And the best way to look at surgical retreatment rates is going to evaluate administrative data rather than institutional series, as patients can move from one place to another. So something to keep in mind as we move forward. So in summary, learning curve and adaptability. Aquablation uses all the tools that most urologists are familiar with already, and we can democratize excellent results for men with BPH. Whereas HoLEP often requires a very long learning curve, plus or minus fellowship training. OR time, no difference. Perioperative safety, no difference. Same-day discharge, HoLEP has been doing this for a little bit longer, but certainly feasible with Aquablation as well. What about IPSS and quality of life, things patients care about? Zero difference. Qmax, HoLEP does have an edge, meaning that Qmax was a little bit higher in HoLEP versus Aquablation, but urinary incontinence, Aquablation statistically clear winner versus HoLEP with 0 or close to 0 rates of stress urinary incontinence. Ejaculatory dysfunction, obviously Aquablation also has a clear advantage. Surgical retreatment, HoLEP has been established for a very long time as an excellent treatment modality with low retreatment rates. And Aquablation, superior to the other methods that are out there, but long-term data still remains to be seen. So in summary, should enucleation or Aquablation be the gold standard for non-catheter dependent BPH? My answer is yes, clearly.